Hey, good morning. Can anybody hear me?
Good morning.
Oh, good. Can you hear me?
Oh, yes, of course.
Oh, good. Okay. I have a new microphone. Hopefully it's a little bit easier to hear now.
Yeah. No, no, it's absolutely clear.
Great. Fantastic.
How are you doing? Thank you.
Good. How are you doing?
All great.
Yeah.
It was a nice month.
It's absolutely disaster here. It's sunny, but we had a foot of snow last night and it's 1 degree outside, 0 degree outside, it's Fahrenheit.
The
It
Fahrenheit.
is really,
My God, that's crazy.
yeah, that's really cold.
Yeah.
Okay, Akshay, I'll be right back. Give me a second. And I'm just gonna run use a restroom and I'll be all set.
Sure. Hi, Vasu, can you hear me?
Yeah, I can hear you. You can hear me, no?
Yeah, loud and clear. Perfect. So Suresh also just logged in.
Yeah, I was there, but I think it was from the participant side.
I think, I don't know, did you get the panelist invite on email?
Uh,
Get that.
I may have missed it. I logged it from your invite, so that was from
Yeah,
the.
that was a attendee link. Yeah.
She changed it too, and Shamina, I called her, so she changed it.
Oh, she changed it. Okay, got it. Okay, perfect. Yeah, so the intro is all here.
Um, I am from. You can see me, na?
Yeah, I can see
ठीक है.
a little bit of the paintings. Very little bit. They should be more prominent.
Hello.
Hi. Good evening. Good.
Hey, how are you?
Good. How are you?
Good.
So I think you met Vasu a few times, including at RSNA last year.
Okay.
These
This
are
past year?
not this year, last year.
Okay.
Yeah, yeah. So she does head neck imaging at Tata, and
Oh, excellent.
always say that she is the best pair of eyes. She can see the most shades of gray amongst all the.
She can see the 50 Shades of Grey.
Yeah. That's right. So she
That's
would.
great. That's great. Thanks for moderating, Vasu.
Yeah, it's my honor to moderate your session.
Thank you. So, Akshay, how much time do you want to have for questions afterwards?
All up to you.
Okay.
You
I
know,
my tennis was canceled, so I'm free.
okay. Well, so there's something for which we need to thank the winter then.
Yeah.
What is the
You play tennis regularly?
Yeah, in this winter time, about 3 times a week. But I'm kind of old right now. I'm injured. My back was tight, and my elbow was hurting from all the golf and tennis in the summer. But yeah, my friend canceled. He's actually an ex-weatherman, and he told me we're going to get a lot of snow yesterday. He said 5 inches, but I think we got a foot, so it's probably better we did cancel.
Yeah, that's crazy. A foot, wow. So I remember this year when there was a lot of snowfall in Chicago during RSNA, and everyone was
Yeah.
landing Saturday just had a torrid time. I mean, there were some people flying in from India who took like I think over 48 hours eventually to reach there because of all the cancellations.
Yeah, yeah. I had to take an Uber up from Chicago, so I found some crazy woman to drive me up. Otherwise, it would have been hard for me to get up there too.
Yeah. I think I was the only one. I was enjoying the snowfall. I was able to, thankfully, reach comfortably, and I was very happy with snowfall. Not something.
You may have been the only one.
Yeah, possibly.
So, I mean, how long can I take the questions? Because the questions will be non-ending.
I think at least a half hour. I may have to get up and get a coffee or something, but I'm all yours today for I blocked out a couple hours, so it's all yours.
Oh, great.
Okay,
That's
thank you.
Suresh, you are just amazing at this because we get so many speakers, but no one really, lets the Q&A flow the way you do. I mean,
Oh, you're sweet.
Yeah, it can continue for another hour, I think.
Well, hopefully we'll get a good turnout.
yeah, no doubt about that. So, I mean, we start at 7 p.m. and because it's India, right? So people trickle in by till 7:10, 7:15 is when it really peaks.
Yeah, yeah.
It's always the case.
How's the registration today? Did you get a lot of people register?
No, we don't need pre-registration. So, no, this link is valid for every webinar. It's the same link. So it's just very convenient for them to, they don't even need a reminder per se. If they have the link with them from any prior session, they just click at 7 o'clock and they just log in.
Okay. And you've never been Zoom bombed then?
Well, that's happened 3, 4 times.
Mm-hmm.
But those were the early days of Zoom when the COVID had hit us and people were having fun on Zoom. So
Mm-hmm.
that happened a few times then, and then I think just once after that. So yeah, only 3 times actually.
Okay. Yeah, no, I got Zoom bombed once this past year. Someone put it, in general, if you keep it in the society, it's fine. Someone put it out on their channel on LinkedIn, and then right at the end it got bombed. But that was the only time. I do 2 or 3 talks every week now,
Yeah.
and I have a group of because with all my faculty appointments, I usually giving 1 or 2 talks a week. So I have this little enclosed group that I invite, and overall, it's been pretty good. It's been pretty good.
Mm.
We haven't had any issues.
Yeah. And the moderator generally can just push the attendee out. So we just block them if something like that happens.
Okay, good. That's good to hear.
Moderator is sort of we just have to say remove attendee and that's it.
Oh, really? And you can tell who's doing it?
Yeah. So, I mean, because this is a webinar mode and not a meeting, Zoom meeting mode. So, anyway, those who
Mm-hmm.
are attending cannot speak, right? So, the max
Ah,
is just type in the chat box. And the moment they type in the chat box, we have their name. And if they are, typing something inappropriate, we can just remove them from the meeting. And then,
so I see. And the webinar, they can't take over the video then.
no, they can't. They can't. They have to be
Okay, that's
to be on as a video to be able to speak. If it's a
Okay,
Zoom
perfect.
meeting mode, then they can, and then everyone can speak.
Okay, perfect. Let me just grab a water real quick too. One sec.
Yeah, so I think as soon as he comes, Vasu, I'll just introduce you, and then you can take over.
Yeah, very important.
Hey, I'm ready whenever you guys are.
Yeah. So let's introduce Vasu, and then she'll take over. Hello, everyone. This is Akshay Baheti, and welcome to today's long-awaited special Sunday with Suresh Mukherjee. And I'm glad to have with us moderating this session my very good friend and colleague from Tata Memorial, Dr. Vasundhara Patil. Dr. Vasundhara focuses on the head neck disease management group along with the pediatric and the hematolymphoid disease management groups in Tata and the neuro disease management group as well. And she will be moderating this session. Looking forward to it.
Thank you, Akshay, for the kind introduction. And it's always an honor for me to introduce and moderate the session of Dr. Suresh Mukherjee. I'm a big fan of his. He needs no introduction. He is internationally known and respected head neck radiologist. He is an authority in head neck imaging. Currently, he is a professor of radiology at University of Louisville and University of Illinois, and a professor of radiation oncology at Robert Woods Johnson Medical School, Rutger University. He is a national director of head neck radiology at ProScan Imaging. He is a Bruce Bradley Fellow, the Leapfrog Group. He is a past president of American Society of Head Neck Radiology and served numerous leadership positions in Radiology Society of North America, the American Roentgen Society, and the American Society of Neuroradiology. And we all know him. We all have read his articles. We all have listened to his lectures on YouTube, and many of us have, including me, have subscribed to his YouTube channel. So we welcome you, sir, for today's lecture on anatomy of and pathology of hypopharynx.
Great. Thanks a lot for having me, and thanks for the kind introduction. Yeah, if you want to subscribe to the YouTube channel, it's free. It's at Suresh Mukherjee 359. So if you go to YouTube, just at Suresh Mukherjee 359, then you can subscribe. We have about 22 videos up there now. And usually when I do something like this, I think Akshay and you guys kindly send me the video link so we can load that up as well too. But I realize I'm not smart enough to create an iPhone, but so my contribution is going to be to education. But thanks for having me. Yeah, I enjoy doing these every Sunday. It seems like it's been a win-win for everyone. Today in the United States, at least where I live in Indiana, we had a foot of snow, and it's sunny outside, but it's 0 degrees Fahrenheit. In fact, I'm looking at my watch right now. I can't believe this is kind of interesting. I'm looking at my watch right now, my Apple phone. It's minus 4 degrees Fahrenheit right now where I live. So I was telling Akshay, my tennis got canceled in the morning. Usually I play on Sunday morning, so I'm all yours for a while. So we're all set to go. So what we're going to do today is that we're going to discuss an area that really doesn't get a lot of attention, but is really an important area in the head and neck. And it's very it's very confusing because in general, when you give talks on quote unquote the larynx and the hypopharynx, the majority of the time is spent on the larynx and nothing's really spent on the hypopharynx. So what today's talk is going to be is that we're going to take a really drill down approach to the hypopharynx. So what we're going to be discussing over the next 50 minutes or so, or maybe 55 minutes, and then we'll have questions, is the technique, how to image the hypopharynx, the anatomy, various tumors, various infections, and a variety of congenital and developmental lesions that can involve the hypopharynx. So the first thing that we'll talk about the technique, and this really varies based on where you are in the world, but in the United States, we tend to perform much more CT than we do MR. And for our CT technique, we always perform multi-detector imaging. Our acquisition now is always sub-millimeters, and then we reconstruct at usually 1 millimeter or more. It really depends. In general, we use 1.5 millimeters with a 0.62 overlap. This really makes for some very nice reformats. One of the pitfalls I still see for some reason, even in 2025, based on the studies that come in, is that there's some places that are still doing CTs without contrast. So just realize for all your neck CTs, especially in patients with cancer, make sure that you give intravenous contrast. Now, what we use is what I refer to as a dual phase technique. We published this back in 2005, and it's nice to see that a lot of people have kind of adopted it. So one of the challenges that we ran into when we first started doing multi-detector CT is that we would give a power injected dose, and then we would acquire. And the next thing you know, excuse me, just about everyone was essentially getting a CT angiogram because we were acquiring so fast. So what we do is that we give 50 cc's, if you will, a loading dose, and then we wait. We don't image. And that purpose of that 50 cc's is to permeate the soft tissues in the neck. So to look at the lymph nodes, if there are any tumors there, to have enough time to get into the mucosa, so on and so forth. And then we give another 25 to 50 cc's. And then when we give that injection, that's when we acquire. And that second phase, the purpose of that is to opacify the vessels. And that helps us distinguish the vessels from the lymph nodes. And sometimes that can be a bit confusing, especially if you don't have good intravascular enhancement. So that's the purpose of that second phase. So that's why we use that dual phase technique. The other thing that's still a little bit confusing, and I understand how it came about, but it's a real easy to fix, especially when you're evaluating the larynx and the hypopharynx. Please do your acquisitions in quiet respiration. Um, there, the reason why we started doing breath hold, again, this is probably before many of you were born, when I was doing my fellowship and even my residency. The reason that we were doing breath holds for neck CTs is that the initial acquisition for each individual image was 30 seconds. So each image was 30 seconds. So if someone was breathing during that 30-second point, you would have a lot of motion artifact just due to the involuntary motion associated with breathing. But then multi-detector came through and just became really, really quick. And the challenge is that if you acquire and you hold your breath, you're not going to be able to see a variety of structures. Now, a lot of those structures are going to be in the larynx, such as the anterior commissure and the posterior commissure. But because the larynx is connected to the hypopharynx, it's just easier to do everything with quiet respiration. So I still see a lot of studies being done with breath hold, and I would implore you not to do breath hold, just do quiet respiration. Obviously right now in 2025 with multi-detector imaging, you can reformat in the sagittal and the coronal planes. We do this routinely. I always kind of joke when I grew up, when I was a resident fellow, we didn't have the luxury of sagittal and coronal formats. Well, we sort of did, but the reconstructions are really bad and we would end up having a lot of stair-step artifacts. But now with the multi-detector imaging, you have to certainly, I'm sure you're including this in all your images. For me, I've kind of had to learn to look at these. I still look at the axial just because for the first 45, 50 years of my life, I didn't really have reformats. But certainly these do help from a problem-solving standpoint. So the next thing that we're going to talk about is the anatomy. And we're going to take a real drill down approach to the anatomy of the hypopharynx because, again, it's an area that really doesn't get a lot of love. So when we look at the hypopharynx, there are three primary components of the hypopharynx. So one component of the hypopharynx is the piriform sinus. The next component is the posterior pharyngeal wall. And then we have this last component, which is the postcricoid region. So when we look at the hypopharynx, we are going to talk about the posterior pharyngeal wall and the innervation of the muscles. So realize that the hypopharynx extends from this area right here. So this specific fold of tissue, extends from the pharynx to the epiglottis, and this is referred to as the pharyngoepiglottic fold. So normally when we talk about the larynx, we can see the epiglottis, but laterally we have this pharyngoepiglottic fold that extends to the lateral pharyngeal wall. So when we look down, when you perform an endoscopy, and we'll show these a little bit later, this fold of tissue is the pharyngoepiglottic fold. And this entrance posteriorly is going to be into the opening of the primary piriform sinus. Then we'll have the posterior pharyngeal wall, and then we have another area which is referred to as the postcricoid region. When we talk about the muscular innervation or the muscular components of the hypopharynx, it's predominantly formed by the inferior constrictor muscle. So you have a little middle constrictor muscle, then you have the inferior constrictor muscle, and then you have this transition here to this muscle, which is the cricopharyngeus muscle, and then we get into the lower portion of the esophagus. And again, everyone is probably familiar with Zenker's diverticulum. That's due to the inability of the coordination of the cricopharyngeus muscle to constrict and relax. We'll talk about that a little bit later. But I do want to point out that the majority of the posterior pharyngeal wall for the hypopharynx is comprised by this inferior constrictor muscle. So let's begin our journey regarding the first component of the hypopharynx. So the first component of the hypopharynx is the piriform sinus, and it's sometimes called the smuggler's fossa. So when we look at the hypopharynx, when we look at the larynx, this is the epiglottis, this is the aryepiglottic fold. So if I was given the talk on the larynx, this is the false vocal cord, this is the true vocal cord. Now what I want you to do is focus your attention posteriorly. So this is the aryepiglottic fold, and this is the piriform sinus. The opening of the piriform sinus is called the introitus. Now, one of the interesting things, and this is important from a staging standpoint, is that notice this aryepiglottic fold is a separation between the larynx and the piriform sinus. So the anterior margin of the epiglottic fold of this anterior mucosa is actually in the larynx, but this posterior mucosa is actually in the hypopharynx and specifically within the piriform sinus. So when we look at the piriform sinus, it almost looks like this inverted pear shape. So when you look at this pear, it's a big bulky area, and this opening of the pear right here at the top of the pear is what we call the introitus. As we go more inferiorly, you can see that this pear starts to narrow, narrow, and narrow, and eventually the pear has this very tiny apex here, and in the apex we have a little stem. So the way to remember the piriform sinus is pretend like you've swallowed a pear. Now, don't do that obviously in real life, but if you remember that you swallowed a pear, you'll be able to understand the appearance and the morphology of the piriform sinus. So when we're looking at this cross-sectional imaging, here's the epiglottis here. This is the beginning of the aryepiglottic fold, and this area right here is the opening or the introitus of the piriform sinus. As we come down more inferiorly, we can see that the aryepiglottic fold is fully formed. This margin is in the larynx, and this margin is in the hypopharynx, and this is the mid portion of the piriform sinus. Now, as I mentioned before, the piriform sinus becomes very, very narrow to this level, and it forms this little apex and a stem. This apex of the piriform sinus is located at the level of the cricoarytenoid joint. So we spend a lot of time talking about the anatomy of the larynx. If you remember that the cricoid and the arytenoid joint form the true vocal cord, you'll always be able to see this area right here, which is the apex of the piriform sinus. So at the level of the true vocal cord is this apex. This is an important landmark in the sense that if you have tumors involving the piriform sinus, if they extend down into the apex of the piriform sinus, then the level 6 lymph nodes are at risk for metastases. So if you have piriform sinus carcinomas and they're mostly superiorly to involve the introitus or the main portion, well, the level 6 nodes are not really at risk. But once these tumors extend to the apex, well, all of a sudden the level 6 lymph nodes are at risk, and we'll talk more about that. But that's why I'm emphasizing so much about where the apex of the piriform sinus is located. The next area that we'll talk about is the posterior pharyngeal wall. So when you look at the pharynx, remember the pharynx is comprised of three primary areas. You have an area at the level of the nasopharynx, then you have a level of the oropharynx, and then you have the hypopharynx. At the level of the oropharynx, the predominant muscular component of the oropharynx is formed by the superior constrictor muscle. The middle constrictor muscle is relatively small and very difficult to see, but as we come down more inferiorly and we get down to the hypopharynx, well, the majority of the muscular sling that forms the posterior pharyngeal wall is formed by the inferior constrictor muscle. So when we're looking at the posterior pharyngeal wall of the hypopharynx, it's pure and simply, this is that posterior pharyngeal wall, which is located here. So when we're looking at the axial images, the posterior pharyngeal wall is pretty easy to see. There's our posterior pharyngeal wall here. At the level of the apex of the piriform sinus, remember the piriform sinuses are located laterally, and then this wall right here is the posterior pharyngeal wall. So as we extend laterally, this is the apex of the piriform sinus, and this is the posterior pharyngeal wall. Now, the posterior pharyngeal wall extends inferiorly and continues posterior to the cricoid cartilage. So this is still all the posterior pharyngeal wall of the hypopharynx. And we'll see in a little while how you can separate that out. Now, one of the unique components of the hypopharynx is a subcomponent of the hypopharynx that's called the postcricoid region. This postcricoid region separates the posterior aspect of the larynx from the hypopharynx. So if we did not have this wall right here, which is sometimes called the common party wall, then the larynx would be contiguous with the hypopharynx. And as a result, if you swallowed something, if you did have food coming down your pharynx, all of a sudden it would be redirected into the larynx. So this this little common party wall acts as a very important separation between the hypopharynx and the larynx. The proper terminology for this is referred to as the postcricoid region. So when you look at this schematic illustration, this is the larynx anteriorly, this is the lumen of the hypopharynx, and this is that this is that common party wall, and in this case, this depicts a tumor involving the postcricoid region. So when we are looking at the larynx, again, this is the this is the cricoid cartilage, this is the arytenoid cartilage. I talked earlier about this is the posterior pharyngeal wall that's located here. This is the apex of the piriform sinus, and that that common party wall is located right here. So it's almost anti-gravity. It is attached to the posterior aspect of the cricoid cartilage. That's why they call it the postcricoid region. If you come down a little bit lower, you can actually see my favorite tiger. Those of you that have come to this talk know about my tiger stripes. So you've got the gray here, you've got the black, you've got the gray, you've got the black, and then you've got the gray. This area posteriorly is going to be the posterior pharyngeal wall. This is the inferior portion of the apex of the piriform sinus. And this black and this gray form the anterior wall of the hypopharynx, which at this level is attached to the back of the cricoid cartilage. So that's our postcricoid region. And again, important to understand this specific piece of anatomy, because when we start talking about tumors in this area, this is a very, very unique area of the hypopharynx. So when we talk about the normal anatomy of the hypopharynx, we know that the hypopharynx is contiguous with the esophagus. So the hypopharynx continues inferiorly and becomes the esophagus. So the challenge is how do we know when the hypopharynx ends and the esophagus begins? Well, one way we can do that is that we look for the hypopharynx. And what I always try to look at and try to remember is that once we're at the level of the true vocal cords, remember the cricoid cartilage kind of smiles at us because we have the cricoid cartilage here. And this area right here is the hypopharynx. So if you're sort of into emojis right now, you can see that we have this smiley emoji. It's just kind of looking at us. So when we look at this anatomic depiction right here, all of this area right here is the hypopharynx. Now what happens is as we get towards the cricoid cartilage, what ends up happening is that you have a little bit more thickening of the hypopharynx. And this thickening is as the hypopharynx begins to transition into the cervical esophagus. These little fibers right here identify the transition between the hypopharynx and the esophagus, and this is what's referred to as the esophageal verge. So it's not yet forming the cervical esophagus, but we're starting to see a transition between the very, very thin smiley face emoji and eventually the surprised emoji. So you can see a little bit of widening right here, and this widening right here identifies that esophageal verge. Now at this level, now we're at the formal presence of the esophagus. So here's our trachea anteriorly. Notice the cricoid cartilage. We only see the cricoid cartilage at this level. There's no cricoid cartilage at the level of the cervical esophagus. Why? Because now we're at the level of the tracheal ring. So in this anatomic dissection, we can see the cricoid cartilage here a little bit widening, but more inferiorly, we can see we're at the first tracheal ring. And if you look at this anatomic illustration of the esophagus, we can see that it's more oval and round compared to the level of the esophageal verge. Now, why is this important? Because from a surgical standpoint, if a patient does have a tumor involving the hypopharynx, it's important to provide this information because this inferior extent at the level of the cervical esophagus has substantial surgical implications. If they do have a tumor that's involving the cervical esophagus, well, the surgeons may then consider performing some type of pull-through procedure where it's just at the level of the hypopharynx, well, maybe they can just get away with a laryngectomy and a pharyngectomy, so more of a standard approach. So this subtle involvement right here, going from the apex of the piriform sinus to the esophageal verge to involve the superior portion of the esophagus, again, very important from a surgical standpoint. So now what we're going to do is that we're going to talk about neoplasms involving the hypopharynx. And far and away, the most common tumor that you'll end up seeing in the hypopharynx is going to be squamous cell carcinoma. So this is the classical example of squamous cell carcinoma. We're going to take a much deeper dive of squamous cell into the various subsites of the hypopharynx. But I do want to point out that there are other tumors that can involve the hypopharynx. This is an example of lymphoma. So this is an example of lymphoma involving the hypopharynx. In general, it's pretty rare. We can have various minor salivary gland tumors involving the hypopharynx. And unfortunately, it's nonspecific. I can't tell the difference between squamous cell carcinoma from lymphoma, from even a neuroendocrine tumor. We just can't do it. One thing that I have sort of learned in the past is that, remember, squamous cell carcinomas tend to be mucosal lesions. So the surgeons can look down with their endoscope, and if they see a mucosal lesion, they can biopsy it, and they can pretty easily make the diagnosis of squamous cell carcinoma. But on the other hand, if they look down and we as a radiologist see a mass involving the hypopharynx, and they look down and they see a completely intact mucosa, totally intact, then I've learned over time that I always consider and raise the possibility of a minor salivary gland tumor. Now, why is that the case? Remember, minor salivary gland tumors are essentially rests of salivary gland tissues that are normally in the parotid, the submandibular glands, and the sublingual glands. During embryological development, those minor rests of tissue get lost. They get placed in the wrong part of the head and neck. That's what we call ectopic salivary gland tissues. If that salivary gland tissues goes to a specific area where it shouldn't be, it could potentially de-differentiate into a malignancy. Because that salivary gland tissue is below the mucosa, that's why these tumors tend to have a predominance to be submucosal, and that overlying mucosa is intact. So that's just one of the tricks I've learned. This is an example of a patient that has a rhabdomyosarcoma involving the posterior pharyngeal wall. The only way I can make this diagnosis again is the fact based on age. So if I see a younger child and we know that the most common malignancy in the head and neck is going to be rhabdomyosarcoma, I'll raise that possibility. And this is an example of a large leiomyosarcoma involving the head and neck. I think if I see something like this in an older adult, notice again it's likely submucosal, I'll go ahead and raise the possibility of some type of sarcoma. And things can really get nonspecific. So this is an example of squamous cell carcinoma involving the apex of the piriform sinus. This was another really ugly lesion here. This turned out to be Candida involving the piriform sinus, and this was an example of tuberculosis. So even if something is an infectious or inflammatory process, we still can't tell the difference. So oftentimes what we have to tell our surgeons is that, hey, there is something going on. This is specifically where to look. And the surgeons and the medical doctors are going to have to determine whether you think you're dealing with a neoplasm or whether you're thinking you're dealing with some type of atypical, in this case, mycobacteria or fungal infection. So when we talk about hypopharyngeal carcinomas, they are relatively rare. They're comprised about 7% of upper aerodigestive tract cancers. The incidence is a little bit greater in males and females. And for those of you that are taking your boards, you may remember that hypopharyngeal carcinomas are associated with a syndrome, and that's the Plummer-Vinson syndrome. It's most common in patients that are 65 years old. I hate to say that because I'm 64, so I'm just a few months away from being 65. So unfortunately, every time I give these talks on cancers, I tend to be in the sweet spot of the demographics because I'm male and I'm old. So therefore, I'm at the highest risk for developing these things. It's also associated with tobacco and alcohol. Now, unlike the oropharynx carcinoma, these are associated with HPV, but very rare. It's only approximately 10%. Now, this number may increase over time as more testing becomes available, but in general, the number that's kind of thrown out there is about 10%. The majority of hypopharyngeal carcinomas will involve the piriform sinus, followed by the posterior pharyngeal wall, and then eventually the postcricoid region. The one nice thing about hypopharyngeal carcinomas is that they are decreasing in incidence over time. So I know in the United States, there's been a large public health initiative to try to decrease the intake of alcohol and specifically smoking. And for me, I like to drink. I'll have a cocktail. I like to drink wine. And so when I go if I go to a wine tasting thing, what's interesting to me is that this generation, meaning you people that are out there, the distillers tell me that the demand for the spirits, if you will, things like bourbon and other type of whiskeys and so on and so forth, are actually decreasing. And they tell me this generation is spending more time with CBD as opposed to spirits, if you will. So I guess there's one good thing is that hopefully your generation is going to have a lower incidence of hypopharyngeal carcinoma because the demand for spirits is much lower than, if you will, my generation. Um, and then also smoking, certainly, there's a lot less smoking in the United States. So again, that's why we see this incidence decreasing. Now, when I go to Europe, I think there's a higher incidence of people that are smoking. I think in India, there's probably still a lot of smoking going on. But in general, in the United States, we are seeing a reduction in drinking and smoking. And is having tangible benefits when we look at the incidence of hypopharyngeal carcinoma. So what is the imaging workup? And again, in the US, we do much more CT than we do with MR. And there are various reasons for that. If I go to Europe and I give them talk in Europe, then they kind of look at me with kind of cross eyes and said, "What do you mean? We do a lot more MR than CT." So part of it is geographic preference. Part of these things are also who owns what imaging techniques or where they're located. In the US, we tend to do a lot more CT, and part of it is the fact that in general, and I don't want to speak for every single institution in the United States, but if you do have a patient in the US that has a hypopharyngeal carcinoma, they're going to get a CT, and most oftentimes they end up getting a PET CT because PET CTs are part of the radiology department. They're integrated. And I think that's one of the reasons that we do this. So that's part of the reason we get it. And in the US, the MR is more of a problem-solving technique. So when we are doing MR for hypopharyngeal carcinomas, we're looking for things like cartilage involvement, and we're also looking for prevertebral space invasion. And again, we'll talk about this a little bit later. You can also do PET MR. This is really localized to cancer centers. How much PET MR is actually superior to PET CT, I think, is a little bit debatable. Certainly, we know the benefits of PET MR, but I know this was a paper that we wrote a few years ago indicating that some of the quantitative results that we get with PET MR when we look at specific glycolytic activity can help better predict response. So PET MR certainly is used, but it's really not scaled as PET CT is in the United States. So let's talk about some of the tumors that involve the piriform sinus. We talked about the normal anatomy of the piriform sinus. We talked about the introitus, the main body of the piriform sinus, and the apex. So this is a schematic illustration of a tumor involving the piriform sinus, and this is an example of a tumor involving the piriform sinus, predominantly involving the apex and extending into the mid-body. So here's an example of a piriform sinus carcinoma. Just yesterday, you guys know that I see patients every Tuesday or Wednesday afternoon. There was one case that our surgeon thought, and I don't have the case yet, it's going to be transferred over to me, that they thought was a laryngeal carcinoma, but in actuality, it's a piriform sinus carcinoma. So how do we know this? Part of it, in this case, it's pretty easy because you can put your arrow right in the middle of where the tumor is and then map it to the opposite side. And now we can see that, yes, this is in the piriform sinus and it's not involving the mid portion of the aryepiglottic fold. Now, one of the things that's important to note, and this is really detailed head and neck, is that notice the normal aryepiglottic fold on the left side. So notice how this margin is located in the piriform sinus. This margin is located in the larynx. So here we can see involvement of the lateral aspect of the aryepiglottic fold, but the medial aspect looks completely normal. So again, this indicates that it's involving the piriform sinus. Here's a tumor that's involving the apex of the piriform sinus. So as I mentioned before, here's the cricoid cartilage, here's the arytenoid cartilage, here's the cricoarytenoid joint. And notice this tumor right here, it's involving this part of the hypopharynx at the level of the cricoarytenoid joint. When you see this, this tells you you're at the apex of the piriform sinus, and this is an example of a CT scan in a patient that has a tumor involving the apex. Again, draw a line down the middle, compare the right side to the left side. The tumor is posterior to the level of the true vocal cord. If you look at the left side, there's the apex of the piriform sinus, and there's this tumor involving the apex of the right piriform sinus. As I mentioned before, if we do see a tumor of the piriform sinus that extends to the apex, then this brings the level 6 lymph nodes at risk. So as a result, if it's being treated with radiation therapy, the radiation oncologists have to make sure they treat the level 6 lymph nodes, which are the central lymph nodes. But on the other hand, if they're being treated with surgery, then the surgeons have to do a central neck dissection. The central neck dissection removes the level 6 lymph nodes, which are between the internal carotid artery. This is not a standard neck dissection, and oftentimes this is predicated on what we say on imaging. So if you do see this inferior extent, that's going to make a huge difference. The next area are tumors involving the posterior pharyngeal wall. So here's a schematic illustration of a posterior pharyngeal wall carcinoma, and this is a CT scan demonstrating a posterior pharyngeal wall tumor. Here's another axial image, schematic illustration demonstrating that posterior pharyngeal wall carcinoma, and this is what we see on MR. Here's an aggressive mass involving the posterior pharyngeal wall. In this case, we can see the normal party wall. That actually looks pretty good, but we can see that this tumor is involving the posterior pharyngeal wall with likely some extension laterally into the apex. And this is an example of a patient that has a postcricoid carcinoma. So this is that common party wall that we talked about. It separates the larynx from the hypopharynx. And here we have a tumor that's involving the posterior party wall. Now, when you're looking at a primary postcricoid tumor, remember you sort of have to think anti-gravity. And what I mean by that is that I just showed an image before of a tumor that's involving the posterior pharyngeal wall. Well, look how the posterior pharyngeal wall actually looks normal. Look where this tumor is. This tumor is involving the common wall between the larynx and the hypopharynx. And you can actually see some separation where this tumor on the left side is abutting the posterior pharynx. But in this case, notice how it's separated between the posterior pharyngeal wall. Another example here, this is a tumor that's involving the common party wall. If you look real closely, look at the back of the cricoid cartilage. So look at the top of the cricoid cartilage. Notice how this cortex is intact. It actually looks like a horseshoe. But look at the back. See this little line right here? See the line on the left and see how it's eroded? And this is an example of a patient that has a tumor involving the postcricoid region. And because of the proximity of the cricoid cartilage, these tumors have a propensity to erode the cricoid cartilage. And there's no way the surgeons can see this clinically. So yes, they may be able to identify that it's involving the party wall, but there's no way to identify that cricoid cartilage erosion. So again, very important to mention that because this is really clinically occult. So when we're looking at patients involving that have hypopharyngeal carcinomas, what's the real information that we can provide? Because as you all know, in patients that have tumors involving the larynx or the hypopharynx, the surgeons can look down, they can see the tumor, and that's great. If you, as the radiologist, say that there's a tumor involving the pharynx or the hypopharynx, that's good, but you really haven't provided them much information. So, what's the information that you can provide? So, for me, I don't necessarily believe in standardized reports. There are some institutions and some people that are very adamant that every report should be the same. For me, I kind of think of my dictation as a piece of art, if you will. But on the other hand, when you do have art, you have to have certain parameters that tell you that it's actually art. So where I'm going with this is that when I am doing my dictations for the hypopharynx, I always try to include what I refer to as key elements. So when you are creating a picture, you have to have the proper brush strokes. So for me, these key elements provide those brush strokes. If you have these key elements, then this is going to provide a lot of information to the referring physician, and it's directly going to affect treatment. So the first piece of information that I always try to provide when I'm looking at a hypopharyngeal carcinoma is this type of spread pattern. Does this tumor cross the midline? So in this case, we have a tumor that's involving the left piriform sinus, and notice how it doesn't cross the midline. But notice in this case, we can see this tumor, this potential spread pattern. And in this case, we have a tumor that's involving the hypopharynx, it's involving the apex of the piriform sinus, and it is crossing the midline. So in this case, if the surgeons were considering surgery, in theory, they can consider doing a partial pharyngectomy, but in this case, they would have to do a total pharyngectomy because this tumor crosses the midline. The next area that we want to look at is whether it involves the thyroarytenoid notch. So when we look at hypopharyngeal carcinomas, one of the interesting things is that these tumors can extend anteriorly, and they can go between this notch, between the thyroid cartilage and the arytenoid cartilage, and this is what we call the thyroarytenoid notch. So this is an example of a piriform sinus carcinoma, and we can see that it's extending anteriorly. This type of spread pattern actually allows me to help separate laryngeal carcinomas from hypopharyngeal carcinomas because this type of spread is more indicative of a hypopharyngeal carcinoma. So if I draw a line down the middle here, I can see my tiger stripes on the right. There's a thyroid cartilage, there's the fat, there's the muscle, there's the fat, there's the mucosa. Notice how this tumor is here, and with a leap of faith, you can see a little bit of enhancing tissue extending into the posterior paralaryngeal space or the paraglottic or paralaryngeal space. There it is right there. There's that tumor. And in this case, it's a little bit more obvious. So this is an example, again, of a piriform sinus carcinoma extending anteriorly. And notice how it's going through the thyroarytenoid notch. If I just saw this appearance by itself, then I'm thinking, is it possible this is a submucosal true vocal cord carcinoma? But notice how this tumor is involving the lateral aspect of the piriform sinus. It's extending anteriorly through the thyroid and the arytenoid, and this indicates to me that this is likely a left piriform sinus carcinoma extending into the thyroarytenoid notch. The next thing that we want to talk about is cartilage invasion. This is something that you should always try to include in your reports. Here's an example of a piriform sinus carcinoma that's eroding the left thyroid cartilage. Now, one thing about thyroid cartilage involvement is that, remember, my thyroid cartilage is going to be different from Akshay's. It's going to be different from Vasu's. They're all going to be different. But in general, when I look at the thyroid cartilage in me, it tends to be symmetric. So in this one patient, if I draw a line down the middle and I compare the right side to the left side, notice this area of the thyroid cartilage is not ossified. But when I look posteriorly, notice this right lamina here is completely ossified. So when I start looking at thyroid cartilage invasion, I really can't comment if a tumor is eroding the thyroid cartilage here. Why? Because the opposite side is not ossified. But on the other hand, when I look more posteriorly to the thyroid cartilage, notice the inner cortex and the outer cortex is eroded. So this one I feel much more comfortable saying there's cartilage invasion. Why? Because when I look at the opposite side, the cartilage is normally ossified in this patient. So when we do look at this lateral erosion on the CT scan, we always have to look at one side compared to the opposite side. We can also perform MR. This is an example of an MR, example of cartilage invasion. Notice this is a T2 weighted images, and what we see here is abnormal signal with T2 with fat sat. What we see here is abnormal signal involving the thyroid cartilage. When we look at thyroid cartilage invasion on MR, there are various ways that we can look at this. We can look at a non-contrast T1 weighted image and look for replacement of the fat. In this case, I've illustrated increased T2 signal, which is suggestive of tumoral involvement. Or we can do a contrast enhanced T1 weighted image and look for abnormal enhancement. Now, in general, we're not 100% at determining whether or not this signal within the thyroid cartilage is due to peritumoral inflammation or whether it's due to tumor. That really is oftentimes up to the pathologist. There are certain criteria that allow us to be a little bit more accurate. But in general, the surgeons that I work with want to know whether or not there's any abnormality involving the cartilage. And then I just kind of say, I don't know whether it's definitely tumor or not, but I want to point that out to you. The next thing that we want to look for is this exolaryngeal spread. Now, the interesting thing about exolaryngeal spread in hypopharyngeal carcinomas, it can be obvious, but sometimes it can be subtle. So when we look at this spread pattern that's extending posteriorly, we're looking for tumor that's extending into the soft tissues. Now, one of the unique things about piriform sinus carcinomas is because they're lateral to the aryepiglottic fold. So here's the arytenoid cartilage, here's the epiglottis. The aryepiglottic fold is going to be located here. Because it's even further laterally, the hypopharyngeal carcinomas are adjacent to a normal natural defect in the larynx that allows early exolaryngeal spread, predominantly in hypopharyngeal carcinomas. And this little defect right here is located between or within the thyrohyoid membrane. This little natural defect allows for the superior laryngeal artery and nerve to extend from outside the larynx into the larynx, because that's how the larynx ends up getting its innervation. So these vessels have to extend inferiorly or internally into the larynx, and this provides a natural egress for tumors. So if I draw a line down the middle here and I compare the right side to the left side, here's the aryepiglottic fold here, here's the piriform sinus. As we extend laterally, notice here we have the superior branches of the superior laryngeal artery and vein complex. And notice how it's being surrounded by normal fat. Now look at this piriform sinus carcinoma. We know now we're experts. It's a piriform sinus carcinoma in the mid-body. But notice how this tumor extends laterally. And look what it's doing to these arteries. It's obliterating the fat along the mid-portion of the arteries. And so this is subtle early exolaryngeal spread. So if you start looking at these piriform sinus carcinomas really closely, you'll be able to identify this early spread. So you just have to look for it. And especially if you are in a big cancer center, you'll be able to identify this spread. And all of a sudden, you're going to upstage these lesions to an early T4. And this is a true T4. You just have to specifically identify where that spread is. And another thing that's important is this involvement of the prevertebral fascia. So back in the old days when we were looking at hypopharyngeal carcinomas, one of the things we wanted to know was whether or not the fascia was invaded. If it was invaded, then this would be a contraindication for the surgeons to perform a pharyngectomy. So in the old days, the surgeons would go down, they would do an endoscopy, and they would tug on the posterior pharyngeal wall. And if it was pliable and movable, then they felt that there was no prevertebral space invasion. But on the other hand, with cross-sectional imaging, now the surgeons are putting just as much emphasis to what we say on imaging. So how do we identify prevertebral fascia involvement? Well, if you look at a CT scan, we can see a mass here involving the posterior pharyngeal wall. And when we look posteriorly, we see a nice fat plane right here. This fat plane is in the retropharyngeal space. Behind the retropharyngeal space are the longus colli muscles. So if we see a nice fat plane right here, we can say with a pretty high degree of confidence there's no prevertebral fascia invasion. But when we look at MR, this is another patient. The finding that we look for to identify that there's invasion of the prevertebral fascia is edema involving the longus colli muscles. So the negative predictive value of CT is really good, but the best way to look for prevertebral fascia invasion is to do an axial T2 weighted MR. And so if you do see this and you do see some edema involving the prevertebral musculature, this is indicative of prevertebral fascia invasion. So from our standpoint, that's the most accurate finding that we look for if we want to look for prevertebral fascia invasion. And then that last thing that we talked about was the spread pattern into the esophageal verge. So remember, when we're at the level of the piriform sinus, in this case, we look at the smiley emoji. We can see the little smiley emoji smiling at us right here. So here's the piriform sinus here. And once we come down to the esophageal verge, we can see the surprised emoji, and it looks very nice and rounded. But on the other hand, notice what's happening in this tumor. This tumor is involving the hypopharynx. It's expanding the esophageal verge. We don't have this nice little normal thin appearance. And then once we get down to the opening of the esophagus, you can see there's tumoral involvement involving the esophagus. So as I mentioned before, if we do say that the hypopharyngeal carcinoma is extending into the esophagus, at most institutions, this is a contraindication to perform a laryngopharyngectomy. Rather, the surgeons are now going to have to perform an esophagectomy and possibly some type of pull-through maneuver. So again, very important from a surgical standpoint. Well, what about nodal metastases? The nodal metastases for piriform sinus carcinomas is predominantly ipsilateral, and it involves levels 2 and 3, predominantly on the ipsilateral side. And again, I'm referring to tumors that are predominantly unilateral. So for unilateral tumor, it brings these lymph nodes at risk. If the tumor crosses midline, all bets are off. Then bilateral lymph nodes involving levels 2 and level 3 are going to be at risk. So when I show an image like this, it's assuming this type of appearance here where the tumor is far lateral. This is an example here of that other type of nodal metastases. So as I mentioned before, when we talk about head and neck, we're oftentimes looking at the string of pearls. But when we are looking at piriform sinus carcinomas and we have tumors that are extending into the esophageal verge, remember now we have these level 6 lymph nodes, and these are the paratracheal lymph nodes. So these level 6 lymph nodes come to at risk. And then also in piriform sinus carcinomas, we also have to look for the retropharyngeal lymph nodes. So notice this metastatic lymph node here, which is involving level 3, but this is another patient with a piriform sinus carcinoma, very, very subtle, but this was a retropharyngeal lymph node. And I've got to tell you, I've seen some very well-known head and neck radiologists that have mentioned these once they were initially missed and then they grow, and they've been called incidental nasopharyngeal carcinomas. When you actually go back and look at it, this was actually a metastatic retropharyngeal lymph node that wasn't seen, and as it grows, it can extend into the retropharyngeal space. So the point is that when you do have these piriform sinus carcinomas, one of these check marks has to be to look at the retropharyngeal lymph nodes. Well, let's talk briefly about some infections that are going to involve the hypopharynx and specifically the retropharyngeal space. This is an example of a huge abscess involving the retropharyngeal space. When we look here, we can see the soft tissue mass that's posteriorly displacing the airway. So this retropharyngeal space is anteriorly displacing the posterior pharyngeal wall, and I think all of us can make the diagnosis of a retropharyngeal space abscess. Another example here, here's the posterior pharyngeal wall. Here's this fluid collection involving the retropharyngeal space. This was due to a nasogastric perforation of the posterior pharyngeal wall. Unfortunately, this was a case of a patient that presented with neck crepitus. We can see all of this air involving the soft tissues of the neck. This patient actually had a post-cricoid carcinoma. Remember, the post-cricoid carcinoma is adjacent to the larynx and the hypopharynx. Unfortunately, this post-cricoid carcinoma perforated, resulting in crepitus involving the soft tissues of the neck. This was a patient that had this huge abscess involving the retropharynx. What this is a little plastic fork. So if you've ever been to like a fair and they have those plastic forks, unfortunately, this child had a plastic fork and it perforated the posterior pharyngeal wall, giving us this large abscess here. And this was a patient that was treated with combined chemotherapy and radiation therapy. We know combined chemo and radiation can give you edema involving the posterior pharyngeal wall. If it gets really bad and very aggressive, you can actually have a fistula that extends from the pharyngeal wall into the retropharyngeal space. And unfortunately, this was a posterior pharyngeal wall fistula that resulted in an abscess involving the retropharyngeal space. Now, one of the interesting infections that can be associated with the hypopharynx is the following. If you have a young child or even a young adult or an adolescent that presents with recurrent neck infections, what we have to always consider is the origin of the neck affection from the thyroid gland. So notice this patient has diffuse swelling involving the soft tissues of the anterior neck. When we look a little bit higher, what we see here is this patient actually has an abscess involving the thyroid gland. If you see this abscess of the thyroid gland, this is extraordinarily unusual to happen on its own. So when you see something like this, you always have to worry about something seeding that gland. And when we look a little bit higher, what we actually saw was a little air-containing tract above the level of the thyroid gland. So what can give you a little air-containing tract? Well, what can happen is that you can have a branchial anomaly, which extends from the apex of the piriform sinus into the thyroid gland. And this tract, which extends from the piriform sinus, can cause secretions that go from the piriform sinus to extend into the thyroid cartilage. And as a result, this can result in a chronic inflammatory process, and if it's untreated, can result in an abscess. And this leads us into our discussion about congenital and developmental lesions that can affect the piriform sinus. So what I'm going to do now is talk about something that's a little bit, I don't know if it's necessarily controversial, but you go to different talks and different speakers and so on and so forth. And what I've always found confusing over the last 35 years is that I go to different talks and I hear what I consider a lot of confusion between third and fourth branchial anomalies. And so what I want to do is at least give you my opinion over my understanding over the last 25 or 30 years, and also based on the embryology and also based on what the histology shows. So this is the normal embryological development of the third branchial apparatus and the third branchial arch. So the third branchial apparatus does have a component that involves the piriform sinus. Now, this third branchial apparatus extends superiorly and then extends inferiorly posterior to the carotid space. So for me, if I see a fluid collection right here, I remember this case and I thought that this was going to be a lymphatic malformation or a low flow vascular malformation. I was quite convinced of this. And then lo and behold, when they took this out, this turned out to be a branchial anomaly. And I couldn't believe it. I'm like, what are you talking about? So when we looked at the histology of this, it turned out to be this type of histology, which was this type of respiratory epithelium. And I was very confused by this. And then I reviewed the embryology and I realized, wow, that's interesting because it is located in the posterior triangle. So now what I do is that if I see this fluid collection or this, defined collection, I still say number one, it could be a lymphatic malformation because 9 times out of 10, that's what it's going to be. But now I also include the possibility of a branchial anomaly. And based on the embryology, I would raise the possibility of a third branchial anomaly just based on the normal development and what's been defined as how this tract develops. This, on the other hand, is the normal development of the fourth branchial apparatus. And notice how this also pierces the piriform sinus, but it extends directly inferiorly. So where I'm going with this is that this was an example of a pathologically proven branchial anomaly. And notice how it's involving the thyroid gland. And this is that sagittal image. So where I'm going with this is that what has been described, but it really hasn't been confirmed, is that some people feel that the opening of the third branchial anomaly into the piriform sinus is a little bit higher than the fourth branchial anomaly. The fourth branchial anomaly is felt to be identified right at the apex of the piriform sinus. So the bottom line is that if I see this cystic collection involving the posterior triangle, in this case, I would consider the possibility of a metastatic lymph node. I would consider possibly a lymphatic malformation. This was a very rare instance that this actually turned out to be a pathologically proven branchial anomaly. And if I see something in the posterior triangle, I'm going to call it a third. But notice this case, notice this air-containing structure that's going from the piriform sinus and now extending into the top of the thyroid gland. Based on this embryology, I'm going to consider that this type of branchial anomaly, which extends from the apex to the thyroid gland, is specifically due to a fourth and not due to a third, because the third should go up and come down, where the fourth should go directly inferiorly. And again, both of these were pathologically proven branchial anomalies. And then the last things that we'll talk about is the classic Zenker's diverticulum. So Zenker's diverticulum is felt to be due to dysfunctional coordination between the inferior constrictor muscle and the cricopharyngeal muscle. So when you are swallowing, the inferior constrictor muscle should contract, but then the cricopharyngeal muscle should relax. So as a result, as you're pushing the food down, the cricopharyngeal muscle should relax, and that's going to cause the food to go inferiorly. If all of a sudden the inferior constrictor muscle contracts and the cricopharyngeal muscle does not relax and it stays contracted, well, all of a sudden you can have this little diverticulum forming. And this diverticulum is what we refer to as the Zenker's diverticulum. So this Zenker's diverticulum extends through this little dehiscence between the inferior constrictor muscle and the cricopharyngeus muscle. This is what we refer to as Killian's dehiscence. And this results in what we refer to as a pulsation diverticulum. So this is the classic Zenker's diverticulum. And as it gets really, really big, it can actually extend inferiorly, posterior to the posterior pharyngeal wall. So this is just an example of Zenker's diverticulum. This is what it looks like on a normal swallowing study. And if you see something like this can kind of look nasty. But when you look real closely, you can see the esophagus posteriorly. And then this is that diverticulum anteriorly. And you can see how the contrast material is actually pooling in that Zenker's diverticulum. So that's the classic pulsation diverticulum associated with a hypopharynx. So in summary, what we've done over the last 55 minutes or so is that we talked about the hypopharynx and we took a really deep dive into it. We talked about the technique. We talked a lot about the anatomy because I don't think it's really fully covered very often. We talked about neoplasms, a little bit about infections, and then we also talked about congenital and developmental lesions. And remember, the third and the fourth are most commonly associated with the hypopharynx, but we also talked about how I kind of separate these based on the location. So thank you very much for your attention, and happy to answer any questions.
Thank you, sir. That was a very wonderful lecture. And every lecture, there's something new to learn, especially the anatomy, the concept that you give about the anatomy, that is really great. And I think I'm always going to remember that tiger stripe whenever I'm going to look at my larynx next time. So we'll take the questions. There are there in the QA as well as chat. I'll start with the QAs.
Okay, great. Okay. Do you want me to do it or do you want me to start? So we're doing the chat or the QA? Which one are we doing?
The QAs
The
first.
QAs. Okay, the QAs first. Okay, so let me find that one. Where's the QA here? I see the chat. Let's see. I'm probably pushing the wrong button here for the QA.
There's a raise hand, share, and then there's a QA.
Okay. Behind share? Okay, let's see. Hold on for a second. Said you're sharing the screen. You know, for some reason, I'm not seeing the QA. Do I do stop share? Will that pop it up or not? No. Oh, there it is. Okay, I had to stop the share. Okay, got it. Okay, great. All right, from the QAs, plain CT needed at all. So to answer that question, I would say don't do a non-contrast CT. And how long do you wait for the second injection? Yeah, that's a good point. I forgot to mention that. Wait usually about 90 seconds. So we give a 50 cc bolus, wait somewhere between 60 and 90 seconds, and then we give the second bolus. So yeah, thanks for asking that. How to say confidently if there's a supraglottic carcinoma with no involvement of the glottis versus glottis and supraglottic carcinoma. I think that's really more, I think this talk was mostly on the hypopharynx. That really is a talk unto its own because you have to, I think I've given that talk before, you have to look at the normal landmarks for the area, the supraglottic larynx, the true vocal cord, and the subglottic larynx. In general, when you're at the true vocal cord, you look for the cricoarytenoid joint. If you look above the true vocal cords and you're at the false vocal cords, you can see the top of the arytenoid cartilage. That's the false vocal cord. When you go below the true vocal cords, then you look for the big O of the cricoid cartilage. So that's what the radiological landmarks are. I'll refer you to the talk that I gave on the larynx. I think it's part of REF, but it's also on the YouTube channel as well. So I would refer you to that one. When the piriform sinus an AR fold, I guess that's AE fold, is above the level of the true vocal cord, people call it supraglottic growth, and the lesion reaching the level of the true cricoid cartilage. Is it correct that we should just call these hypopharyngeal growth? Yeah, I think so. I would just call it extension along the hypopharynx and say that it's involving the introitus. I tend not to use the term supraglottic growth of a hypopharyngeal carcinoma because the supraglottis identifies a tumor in a different area that involves the larynx. Well, as we talked today, that the hypopharynx is a completely different location. Okay, I got it. AR is equal to AE. Got it. Follow-up imaging. Follow-up imaging you recommend. Yeah, that's a really good question. It's very debatable and it's evolving right now. The rule of thumb is that you should get your first imaging study 3 months after the completion of treatment, whether it's surgery or whether it's combined chemotherapy and radiation therapy. 3 months, I really don't recommend doing anything before 3 months. I've seen several cases where referring physicians have gotten it within 6 weeks and they see this very big, robust response. And they assume that it's tumor, but it's not. So that's sometimes the effects of treatment. So for me, it's 3 months. Whether you do a PET CT or whether you just do cross-sectional imaging, again, it's kind of debatable. I would say that if you have a low volume tumor and with an early stage, I think probably just cross-sectional imaging at 3 months is fine. But on the other hand, if you have something that's more advanced stage and there are clinical symptoms suggestive of recurrence, then probably getting a PET CT. But realize this post-treatment surveillance is rapidly evolving. In fact, we're going to have a journal club for our department in January in talking about some new information as to the real impact of post-treatment surveillance. And also, my feeling is that the new with the circulating tumor DNA, the ctDNA, my sense is that we're going to be putting as much, if not more, emphasis on ctDNA levels as we do post-surveillance imaging. But that's kind of my view into the future. We'll just have to see how that kind of evolves over the next few years.
With that, sir, I think we really need your lecture on post-treatment imaging.
I'll have to develop one after I have my journal club. So, give me a little bit of time on that. But yeah, no, I'd be happy to do it. But I want to make sure if I give a talk, there's some evidence based behind it as opposed to opinion. So thanks. I'll do that for you guys. Okay, for sure.
Chemo
Yeah, go
as
ahead.
immuno. We actually don't know where do we stand for all head neck regions, the chemotherapy response and the immuno responses, if you have.
Right. Yeah, that's so true. That's so true. Um, all right. So follow, we tried, I think post-treatment we talked, post-cricoid is the post-cricoid region. I think we did talk about that's the same as the esophageal verge. I think we covered that pretty well in detail. If not, you can go back and look at the lecture and those specific slides. Um, Please tell us the references to read on anatomy. You know, there's yeah, that's really evolved over time. Back when I still think that you should go and read the Netter textbooks. A lot of the images that I have from the Netter textbooks, I think what I tried to do in this talk specifically, because I know how confusing the hypopharynx is, I think I did a reasonable job going over the normal anatomy. So I'd encourage you to go to REF and look at the talk that's there, or if you want to go to the YouTube channel, that's fine too. Slow it down. But in general, there's so much content available on the internet right now regarding normal cross-sectional imaging. So unlike in the prior days where we would have to look for a book and look for the images, here there's so much stuff available. So I would just say, go to the internet or slow down one of these talks, and that should be pretty good for the anatomy.
Suresh,
Cancer
I
layer.
remember
Yeah.
when I was a resident, there was exactly one book which we all used to refer to for anatomy. And it was a book written by you along with Peter Som and Hugh Curtin. So, and I think that still holds true, for anyone who wants to understand anatomy, nothing better than Suresh's book.
Yeah, agree. So,
You're sweet, Akshay. I'll send you the check in the mail for that, okay? No, the nice thing about doing this is that, Akshay is now a senior person, and I think I taught probably the generation older than you. And now you have Vasu, now he's probably a generation younger than you. Now you have the residents. So I kind of always joke, I guess I'm spanning 4 generations of radiologists in India right now. So, which is kind of fun, in a way. You can, it's nice to see the young people come up and like yourself, you're the classic example of someone who's been so successful. So it gives me a lot of pleasure to see how successful you've been and Ref, and that's why I like to volunteer my time to just try to help educate people.
some
So
question.
yeah,
Yeah, even
yeah, go ahead.
I wanted to ask you, you have an article on spectral CT. What is your experience regarding the larynx, the cartilage involvement with your spectral CT?
Yeah, I think we wrote an article years ago on spectral CT. That was when I was in Michigan, we got the first spectral CT and we started using it. And then a couple people have written on some irregularity in the larynx on spectral CT. So I would say, again, it can sort of be used in problem solving. The challenge, quantitative imaging is great. Don't get me wrong. I think it's fantastic. You know, the American Society of Functional Neuroradiology, which I've spoken at before, is a great society. It's all about quantitative imaging. The challenge that you get into is number one, is it reproducible and is it scalable? So if you have certain data coming out at one institution and your referring physicians are comfortable with that information, then I think quantitative imaging is great. The challenge is that how do you scale it? So how do you get the same results at Tata that you can get at MD Anderson, that you can get at Memorial Sloan Kettering? Because there's so much variability once we start using the spectral imaging. So for me, I think the things on the larynx, yes, you can see irregularities, but I don't think I would make a judgment regarding whether a lesion is T3 or T4 or whether to resect a total laryngectomy versus a partial laryngectomy just based on spectral imaging alone. So I think it can be used as a problem-solving technique. I think you have a CT scan and you're a little concerned about whether there's cartilage invasion and you have experience using spectral CT. I think that can help push you one way or the other, but I don't think that should be the primary. I don't think that should be the primary determining factor when it comes to cartilage erosion. What's been your experience, Vasu?
We just have started our spectral CT and the other is going to get installed. So I was asking you.
Yeah, so I would just be a little circumspect to make sure that your image quality is good and that your patients hold still. I know in India, I know 25, 30 years ago, the cancers were incredibly advanced. Now, the healthcare in India is much better, and there's much more imaging available. So where I'm going is that in patients that have a lot of advanced larynx cancers, it's hard for them to hold still, and therefore that's going to degrade your data for your spectral imaging. But on the other hand, if you do have patients with early stage carcinomas, then I think you're more likely to get better data for your spectral imaging.
So if you have to lay down the recommendation, you will still recommend CT as the first imaging modality, followed by MR for problem solving for larynx, hypopharynx areas.
You know, I mean, I would. That's what we do in the US at the majority of places, but I would put a modifier and I would say whatever your team wants to do, because like for Penn, you know, at Penn with Lori there and others, you know, they've always do a lot of MR. You know, in Europe for sure, they do much more MR than they do CT. I think part of it too is that, you know, I get to Europe a fair amount, and they're fantastic radiologists there. I think part of it is that the PET group, the nuclear medicine group, tends to have a separate department compared to radiology. So I don't know how much that plays a role, but in general, when I do talk to my colleagues in Europe and I'll say, well, what about a PET CT? Well, they'll say, well, that's a completely different department. In the US, it's a little bit more integrated, so I think it's easier to get the CT and the PET CT. So, you know, personally, um, I think part of it too is how we pay for things in the US. And if you're going to get a PET CT, you might as well get the CT and the PET CT together, because the patients are going to have it anyway. Whereas if you're not going to get a PET CT, you can make the argument that you'll do MR as a first pass. The other thing about the US, and I don't want to go too long about this, but when you work closely with your surgeons and your radiation oncologist, another reason for doing PET CT initially is number one, the surgeons don't want to operate on a T2, T3, or T4 lesion and then be surprised that there's a distant metastases, right? That's the last thing that a surgeon wants to do. So that's why I would say the majority of institutions end up getting a PET CT on all head and neck cancers. Similarly, from a radiation oncology standpoint, they're doing a lot of their tumor volume, and they're doing a lot of their contouring based on a combination of the anatomic abnormality they do on the CT and the abnormal uptake that they see on the PET imaging. So they're getting both anyway. So then you really have to justify why in the US, when patients have to oftentimes pay for their imaging studies just like they do in India, is it really justified to spend another $1,000 or $1,500 to get that MR? So, that's my opinion on that. But I think, either one is fine. But if you're asking me, I would just say, yeah, CT and PET CT for the reasons I described.
Thank you. Now there's a question, how to differentiate pharyngeal abscess versus tumor with necrosis? Only how do you go about it? By solid component or?
Yeah, I'm sorry. What was the first one you said? I got the second part. What was the first? How to differentiate? What was it? How to differentiate what now? The first part?
Abscess versus tumor.
So, did you say cyst?
It's abscess.
Oh, abscess versus tumor. Oh, okay. I got it. Yeah, that's a really good question. I think, to be honest with you, clinically, it's going to be pretty easy to separate out because if you have a abscess involving the hypopharynx or the posterior pharyngeal wall, it's going to be pretty straightforward. In general, the abscesses are going to have a very thin rim of an enhancement, whereas the necrotic tumors are going to have more of a shaggy wall. Yeah, that's probably the best answer I can give. Remember, don't read these things in isolation. Make sure that you interpret them in the full clinical context.
Yeah. And clinical picture also matters.
Mhm.
Any more question? Just let me check. Mm. Any AI tool you are using right now for hypopharyngeal pathologies?
No, not really. I kind of laugh because when I'm looking at the head and neck, there's a lot of investigations going on various AI technologies. I'm on a couple of chat groups. There's actually someone here from the UK. My colleagues in the UK, when I'm in the chat groups, the one thing that generates the most interest in the chat groups that are centered out of the UK is ultrasound. So in the US, head and neck radiologists tend not to do a lot of ultrasound, but it seems like in the UK, the head and neck folks do a lot of ultrasound. And as a result, there's a lot of investigations going on regarding using AI generated algorithms to help uh, risk stratify thyroid nodules and specifically trying to, I believe, correlate these with the TIRADS criteria. We don't do as much of that in the US. It's very important work, but they clearly have a more experience than we do. What I think is going to be really interesting for us is uh, taking the neck CT. So it's not necessarily AI for hypopharyngeal carcinomas, but as a head and neck radiologist, you, you're responsible for everything on the film, right? So you have to look at the brain, you have to look at the lungs, so on and so forth. But we as head and neck radiologists, just like the neuro guys don't like to look below the skull base. I mean, I am a neuroradiologist, so I do look at brains, I look at spines and so on and so forth. But in general, when I'm looking at a neck CT, you know, I I would prefer to look at from the skull base down to the level of the clavicles and not below the clavicles or above the skull base. But I think and I have experienced this myself, is that we have about 20 AI algorithms that we're using in our practice. In fact, one of the biggest innovations at RSNA that I found this year was the ability to customize foundation models in your own individual practice. So you don't necessarily have to buy all off-the-shelf equipment or off-the-shelf algorithms. But what's interesting to me was if you take your neck CT and you have a AI model such that you have a subscription model, we're now taking all of our neck CTs and we're running it through a brain aneurysm detection model. And we have picked up brain aneurysms on neck CT. So for me, I think one of the biggest advantages for AI, quote unquote, in the neck, I don't know if AI is going to be powerful enough to help us identify metastatic lymph nodes or, help or actually do agentic contouring of an oropharyngeal cancer, but I think it is going to help us better identify aneurysms because I've seen it myself. And similarly, I think it's going to help us identify incidentally pulmonary nodules because, I think if you give a lot of people truth serum, how much time are they really spending looking at the brain and especially looking at the brain vessels, and how much time are they really spending looking at the mediastinum or the lungs? And I think that's where AI, as it relates to the head and neck, will have a substantial impact to help improve our overall quality.
Yeah, we still don't have. I think we'll also get the software for aneurysm, and I hope we get something for the neck nodes also. It's a pain. So with that, I'll ask you for this retropharyngeal node. The surgeon keeps asking us, what do you think it is? What criteria do you use for these retropharyngeal nodes? It's not related to this topic, but still.
Yeah, no, that's a great question. I think it's interesting about the nodes is that the lymph nodes are always a super controversial issue. And what I use as my size criteria for the regular lymph nodes was the landmark paper written by Hugh Curtin and Tony Mancuso and Peter Som back in 2000s that was published in Radiology. And that was the only evidence-based paper that was prospective and that was funded by the National Institutes of Health. And those measurements were the longest measurement in the axial plane. But those lymph nodes covered levels 1, 2, 3, 4, and 5. They did not cover the retropharyngeal lymph nodes because it was only about 3 or 4 years later people really became comfortable identifying metastatic retropharyngeal lymph nodes. So there's no real hard evidence identifying a correlation between what we see on imaging and what is a metastatic lymph node, unlike what we have in the rest of the neck nodes. So the criteria that I use is somewhere between 7 and 10. Now, having said that, this is specifically what I look for is number one, in kids, there is no criteria for any lymph node. So kids oftentimes have enlarged retropharyngeal lymph nodes. So if the child does have a large nasopharyngeal carcinoma and you see big lymph nodes, then they're probably involved. But on the other hand, if you do a regular brain MRI on kids, they have big retropharyngeal lymph nodes. So take the size criteria, throw it out the window for kids. As you get into late adolescence and early adulthood and late adulthood, for me, the criteria is 7 to 10. But on the other hand, it also has to be, if I am going to call a metastatic retropharyngeal lymph node, I like to look for asymmetry. And I also like to look for that asymmetrical enlargement on the ipsilateral side of the tumor. So for me, I don't necessarily say they're all abnormal. I mean, if I see like a 10 millimeter lymph node on one side and nothing on the other side, I will definitely mention that in my report. So that's kind of my approach to it. I hope I didn't confuse you, but 7 to 10 tends to be the cutoff that we use.
Sometimes they are really long but very thin. I mean, elongated but not much in the eggshell diameter. So that is
Right, right. And you raise a really good point. I think it's whatever your referring physicians are most comfortable with. I remember asking Hugh Curtin after it was called the RDOG study, the Radiology Diagnostic Oncology Group study. And so we had a conversation about lymph nodes. He said, well, the size doesn't matter. It's whatever you and your referring physicians agree upon. Because I was I was at RSNA, and then we had a very well-known, respected, experienced head neck radiologist on our panel, and she measured them in three dimensions. And then there was somebody else I talked to that measured them in 2 dimensions. And then other people were doing reformats. So I just keep it simple, and I can always default to the RDOG study because that is level 1 evidence, and that's kind of what I do.
okay. That was really great. Thank you. Regarding the thyroid cartilage, for unossified cartilage, how do you see for erosions?
You can't. You can't. I won't. I will not call on CT. I will not call cartilage invasion in an area if on the contralateral side the cartilage is unossified.
So in that case, do you do an MR? I mean, how do you say?
Yeah, I think it depends on the context, I guess. So I think in the real world, what ends up happening is that cartilage invasion, let me put it this way. If someone comes in and they have a fixed cord, okay, let's just say if you have a supraglottic or a glottic carcinoma and they have a fixed vocal cord, they're already T3. Um, and now you're starting to wonder whether there's a little bit of erosion of the inner or the outer cortex. Well, the patient's already a T3. So then the conversation comes in is, what type of treatment are you going to have? Are you going to have a total laryngectomy? Or are you going to have a partial laryngectomy? Or do you want to be treated with chemotherapy and radiation therapy? In general, with a T3 lesion and the team decides to treat with chemotherapy, it doesn't really matter too much whether there's erosion of the inner or the outer cortex. Now, on the other hand, if someone comes in and they have a T2 lesion, and now you're worried about erosion of the inner outer cortex, and you may push someone for chemotherapy, well, and the surgeons, or excuse me, the medical oncologists are going to be really dogmatic, and they say, well, I want to know whether that cartilage is involved, then we would probably do MR as a problem-solving technique. So to me, that's where the real pivot comes in. I don't know if that answered your questions or not, but when I'm sitting in our tumor board and we're making those decisions, that's why we do so few MRs for problem solving for cartilage invasion, because usually there are other factors that come into play, and those factors include different types of spread patterns, whether or not the vocal cord mobility, and also, oftentimes is the patient a surgical candidate? We as radiologists sometimes tend to forget about that. If you have someone that's 75 or 80 years old that has a lot of emphysema, they may not survive the surgery, so they're going to get treated with chemotherapy anyway. Whereas maybe in a younger patient that's more of a surgical candidate, then that could be an important triage.
Yeah, agreed. It's the dilemma is only certain times when the radiation oncologist doesn't want to give the RT and push it towards the surgeon. Yeah.
Right. Or give chemo, or maybe they're trying to give whether or not they should give chemo or not. Right.
So I think I've taken all the QAs. That was a wonderful lecture. There's one comment that is about what you said earlier. You don't like 64, more like 38, and I agree with it.
I look more like what? What was that? I don't look 64. Thank you.
Like
How old
38.
do I? 38. Okay. All right. I'll give you guys numerous more lectures. And then I just got a new setup now too. I have like a little Zoom setup here. I've got lights. I gave a talk one time and it was nighttime, and the people that give the talk kind of mentioned your lighting wasn't good. So over on Amazon Black Friday, I got like a new microphone and lights. So maybe the lights are good for my skin or something. I don't know.
But agreed completely. So that
Thank
brings.
you. Oh, and before I forget, I am going to be at IRIA. We are doing a workshop, a head and neck workshop. I just checked with Varsha. It's Varsha, myself, Sagat, and Anaga. I think we're going to do a workshop, and I think there are 12 seats remaining. I think we're going to limit it at 60. So I just checked with Varsha, and they're 48. So if anybody is going to our IRIA and they want a 5-hour workshop on head and neck, I think I'm doing 3 of the sessions. You're welcome to sign up for that.
That will be a great learning from all the masters. I think everyone, whoever can, should avail this opportunity.
Yeah.
No more quick QAs. Just let me check the last time.
Yeah, sure. I'm not going anywhere. It's the temperature has risen now. Okay, it's now at 0 degrees outside.
Okay. No, that's all. So I think that's all for today. It was really wonderful. As always, there's lots to learn from all your lectures every time we listen to it. And they are there available on they will be, I mean, many of your lectures are available on your YouTube. So
Okay, I think you guys will send me a download, right, for this one at some point.
Akshay is,
Yes, we will be sending the download.
Okay, sounds great. And then
Absolutely.
I'll talk to you about next year. Then we'll set it up for next year then.
Absolutely, absolutely. So, just for the audience, Suresh is going to continue this lovely series of, Sundays with Suresh Mukherjee next year as well. And hopefully we'll soon be covering the entire head neck anatomy and pathology. So definitely I'll lock down the dates for next year soon, Suresh.
Okay, sounds great. All right, keep up the great work. I really appreciate what you guys are doing. And thanks everyone for attending.
thank you, sir.
Thanks a lot. Have a
Take care.
lovely day.
You
And
too.
hopefully
Take
the
care.
weather will take a turn for the better and you will play tennis soon.
Thank you. I appreciate it. Have a good day.
Thank you, sir.
All right, bye-bye.
Bye.